work really, really hard and do mobilizations and exercises and crank on them, and you could get them up to 155, and you send them back to the ortho that next day, and your note says they were 155, and then the ortho has their note and says they're at 120. Whoa, wait a second. How did they lose all that motion? It's because the patient's walking into the orthopedist's office cold. They're not putting them on an arm bicycle. They're not heating them up with ultrasound or a hot pack, or they're not doing soft tissue and mobilizing and getting them all warmed up and then taking the motion. They're saying, all right, how are you doing? Okay, raise it up. And they're taking their measurement cold. And most of the time they're not using a goniometer. They're just eyeballing.
Do they actually use the goniometer?
They do not. So be prepared for that. So when you're treating, I would take the initial measurement cold, so you know where they are, cold. And then if you're working with a patient who's getting ready to go back to see a physician, an orthopedist especially, warn them. So this is the number that we got here in therapy after all this work, after 30 minutes of working on you. But when you go to your follow-up appointment, your doctor's just going to say, raise your arm, and there you are. So if you want to stretch a little beforehand, do some self-mobs, great, but realize they're going to measure you cold. So if you were to do a measurement, a range of motion measurement from a sitting or a standing position for abduction, flexion, or scaption, what's going to change? What's going to change with your technique, with your form, with what you do? Anything?
The height of the bed.
What? They're sitting up.
So if you're sitting, if they're laying, you have to have them up higher, but if they're sitting, you're going to have them up higher to get it eye level. I don't know. The difference.
Okay. Well, they would be sitting or standing, one or the other. Perhaps.
The effect of gravity is a little different, so you have to give them different cues to compensate or to avoid certain compensations.
Yes. So when we measure in supine, gravity is pretty much eliminated. They have some friction if they're dragging along the table, but gravity is not an acting force. Gravity is helping us keep the arm in the frontal plane for abduction, or when we get above 90, we'll talk about after our manual muscle test and Therex. Once you get above 90, then gravity is helping you get more range of motion. But when you're upright, that's another reason why patients don't usually have as high of a range of motion when they go to their doctor's office, is because they're just sitting or standing, and the doctor says raise your arm. So now gravity is working against them, so if they're painful or they're weak, now they're not going to be able to go as far because they just can't lift their arm as far against gravity in abduction or flexion. And as Brian was saying, you're going to look at whole body movements. So if I'm trying to abduct my arm, I may be a little teapot, trying to help myself get some more range of motion by laterally flexing the spine. So I may be doing this, again, to try to lift. And that's more prominent when you're upright, when you're standing, or when you're sitting. And flexing, we don't have a table behind us, so your patient may arch and extend through the lumbar, the thoracic spine to try to get some more flexion motion. So just be aware of these.
I mean, you've got a lot of different things to maintain with that.
Yeah, so you may park them up against the wall if you need to.
Changes the game a lot.
Yeah, so gravity is a big factor. And we're going to talk about gravity and the glenohumeral joint later. All right. How do you guys feel with range of motion? Pretty good? Do you still remember your flexion and your extension okay? All right. So very similar. Scaption. Just everybody get your hands abducted. Okay. And then come forward about 30 degrees, so not 45. So there's 90. There's 180. All right. There's 45, so go back a little ways. So scaption. If you just think about as your scapula run off the side of your body, you're just going straight up from that instead of completely abducted. It's when you're not in your nice, perfect scapular retraction position. All right, so there's your scaption. So thumb up, open can, allows greater movement. You can get more range of motion. If you high can you get in that scaption plane or abduction plane? Can you go as high with your thumb down?
No.
No. You're gonna jam in there, you can't go any further. So thumb down focuses a lot on supraspinatus, which we'll talk about with manual muscle tests, but you're limited in how much motion you can do. So if you want maximum range of motion, less impingement, thumbs up.